About the situation in Wales, we have a long history of drug use. We really like our drugs in Wales, as well as our alcohol. We have a substantial injecting population as well. But over the last few years, much as everywhere else, we have seen a change in the drugs market. I've worked in drug services and frontline and in research for 25 years. And I have to say the last 8 or so, 10 years has been a real revelation, because I've had to learn a lot of new things. Changes in terms of the way people are using their drugs, taking their drugs, but also in the drugs available. We have been hit quite hard with new psychoactive substances and injecting of new psychoactive substances amongst our historic opioid using population. We also have extensive use of steroid and image enhancing drugs, and that's just growing. So I actually lived in Ireland, in Bantry. It was a beautiful place, for a number of years, and so have some sense of the picture in Ireland, but I know it's been a very movable feast and is continuing to change. So I think we have some comparators there.
That's great. And what evidence do you have for the effectiveness of this strategy, in particular drug testing in the Witness Project?
Well, one of the things, as I said when I started, we really didn't have a role. So my first part was to look at what evidence we had on the nature, scale and harms associated with drug use and drug and alcohol use. I've heard polydrug use, the term used, and it's very much representative of the patterns of drug use that we see in Wales. We started off by undertaking and continue to undertake an annual prevalence estimate of problematic drug use, so that we're able to quantify the population by demographics, but also by drug type and changing drug type. And I think that's been really key, because when I started, I think they based the resources available for substance misuse on the number of people in treatment. Completely erroneous, a very small subset, I think it's fair to say. So that kind of research and prevalence estimation is key. In addition, we have developed the Harm Reduction Database, which is a national data collection system right across Wales. It's covering off all of our needle exchanges, so 257 needle exchanges, all of our treatment services, naloxone services. So we have a much better picture of individuals who are accessing our services, but only, for example, needle exchange, no other treatment services, so that we can really target investment where and when it's needed. I touched on the steroid and image enhancing drugs. We've developed a website and a survey, and we've just completed the first of its kind, actually, 700 face-to-face interviews with steroid and image enhancing drug users in terms of both the harms that they've experienced, the nature of their use, but also contact with health services, which is minimal. So we can really explore. We know now that there is evidence of blood-borne virus infection and poor injecting practice amongst this population, but absolutely no contact with treatment service. And finally, the ODriscoll project, which is a service that tests, enables any individual across Wales to submit a sample of drugs, new psychoactives predominantly, but often combinations of drugs and very often unknown. And we've been running this project since 2013. It's funded by Welsh Government. And as I said, any individual is able to submit anonymously a sample. We ask age, gender, and whereabouts, area of residence, so that we can map trends in availability of drug use, the types of drugs that are available, but also the harms associated with use and who's using. I've heard a lot today about young people, but actually our new psychoactive population runs to, I think our oldest person who's submitting is around 68. And the greatest growth in our contact with treatment services and hospitals is in an older population. And without the evidence, you cannot tailor services to meet these needs. So it's the whole age range that we're seeing. So any individual is able to submit a sample, and in addition we receive samples from amnesty bins in our nightclubs, for example, and we're able to test any sample for non-evidentiary. This is a health intervention. We provide the testing in our laboratory, and we publish all the findings on the website so that individuals can be better informed. So we publish what people thought they had bought, what it actually contained, the legal status of the contents of that drug, and also the harms that individuals who have used, and the best evidence from our National Poisons Information Service have been able to find in relation to these drugs.
Great. You know, we spoke yesterday and you told me that in the 2.5 years that this project has been set up, you've received over 4,000 samples. Can you please tell me maybe, you know, is this really a solution to get like hard to reach people? Is you know, people that might not normally come forward and, you know, maybe might not respond to education? Can you explain maybe the awareness, you know, and the importance and effectiveness in reaching hard to reach populations?
I think the project is innovative in that it is, I believe, the only one that actually recognises the importance of communicating with people who are using drugs. Very often projects, and I've worked in health for a long time, we're very good at informing other health professionals or academics and writing papers. We're very, very poor at recognising that actually people are making choices out there. So I think this project, as well as the other projects, the steroid project, for example, but also the data systems, allow us to identify those people who are in effect hidden from our services, maybe even also from criminal justice, which is a good thing. And it provides a mechanism where people feel more confident about being open about their drug use and engaging in a respectful communication so that they can reduce their own harm. And I think that's absolutely vital.
Thank you very much. Aisling, I'd like to turn to the conversation around decriminalization. I first came into contact with your organisation, Human Rights Watch, at United Nations Commission on Narcotic Drugs a number of years ago, and since then I've just been, you know, just keeping up to date around the kind of work you're doing. You recently came out with a position supporting decriminalization. Why would decriminalization be a victory for human rights?
Thanks, Graham. Yeah, it's true. So Human Rights Watch is an international human rights organisation, and along the model of Amnesty International, if you like. And what had happened was that for a number of decades, the organisation had been documenting the damage and the serious human rights violation that the war on drugs was causing. Everything from attempts at crop eradication, how it was affecting people on the ground, to mass incarceration, to violations of the right to health. And we were coming out with reports that obviously identified what the violations were, and we're calling on governments to stop those abuses and adopt better, more pro-health policies. But we didn't call for decriminalization because under international law, that's not an obligation as such. That's not where the law is right now. But there was more and more growing calls from UN experts, from the UN Special Rapporteur, the expert on the right to health, from UN AIDS, from expert bodies saying, you know, there should be decriminalization. And also at a political level, the Global Commission on Drugs was making the case for decriminalization. And we had to have that conversation within the organization, across the whole organization. So people who work with people who use drugs and drug violations in Asia and in Africa, here in Europe, or people who work on children's rights, women's rights, and particularly people from our Health and Human Rights Division. And we decided that we couldn't keep making recommendations about how to end the violations without also calling clearly for decriminalization. That as long as you had a drug control policy which was based on criminalizing people who use drugs, that everything else you were doing in terms of a human rights approach was being compromised. And so I think, you know, it's clear that for us a decriminalization approach allows you then to properly place a response to drugs and put in drug control policies that governments can pursue in a way which one, recognises that people who use drugs have rights as well, and you don't dismiss that. And it places it, as what we've already heard today from the first panel from the Minister and Jonathan O'Brien, is that this needs to be a public health focus. And if you look at the language that is now coming out at a human rights level, and the kind of the debates you're talking about at the UN and what will happen in April at the General Assembly, it's very clear that the right to health, and the leading expert from UNIS said this, the right to health which the Irish government has signed up to and is a party to that treaty, doesn't just mean that health harm reduction schemes and options are kind of a policy option. They're an obligation. If you want to fully realise the right to health, then the government has a clear obligation to introduce harm reduction strategies, and this is something that we've had quite a bit of discussion about as well, is to dedicate to that the appropriate budget, and so to the maximum of the available resources to properly realise harm reduction strategies. So, as I said, we had come to a stage where we could only go so far in documenting violations and calling for an end to them, without realising that until you lift the stigmatisation and the barriers that the criminal law causes, that we couldn't really have a proper human rights based approach. And so that's why, and ironically, well maybe not ironically, but maybe strangely, I think it's on next Tuesday, will be the first report that we're doing which actually takes on just kind of full-scale drug reform process, which is happening in Tunisia, of maybe all places, and they're looking to reform the drug law, and it'll be progress from where they are, but we're saying it doesn't go far enough, and we're hoping that this may be an opportunity that they will actually see proper decriminalisation. So that will be one victory.
That's great. So you discussed a number of agencies there, a number of international organisations and countries as well. Tunisia, we know even close to home here in Europe, we have Portugal, that have implemented decriminalisation. So in your opinion, is there, I suppose, an emergence in international human rights law that there is an obligation on nation states to provide access to not only treatment but also medically supervised injection facilities, drug consumption rooms, drug testing, and the kind of conversations that we're having here in Ireland? Is that an obligation, would you say, under the right to health?
Yes and no. What is clear as an obligation of the right to health is that there needs to be harm reduction strategies. Now, as we know, harm reduction strategies can be very, very many, everything from education to outreach to safe injection centres to needle exchange programmes, proper treatment, access to effective treatment in prisons, in incarceration. I mean, it's ironic that we put people in jail for using, and then in where we put them, apparently to help them, they don't get access to effective treatment. And we've already discussed the dearth of treatment on the outside as well. So I mean, I couldn't hand on heart tell you as a lawyer and say there's a strict obligation to ensure that there are safe injection rooms and that there are drug testing kits at venues where drugs may be consumed in that. But is there an obligation to ensure safe needle exchange? Is there an obligation to ensure proper access and proper availability of treatment and substitute treatment? Absolutely. And I think then we have to go down through all the different options that fall under a harm reduction strategy to say, where's the strongest obligation stand. But certainly in terms of access to substitution therapy, to effective treatment, and ones where it's not stigmatised, and where if you come in contact with your public health services, that you may also be diverted or come in contact parallel with the criminal justice system. So I can't, that's as much as I can tell you in terms of
Thanks very much for the very clear answer there, because international law is very tricky, so it's a question that I've asked for a long time, so thank you for providing a very clear answer there. I'd like to bring it back home to Ireland now, and we're joined here with Denis O'Driscoll. Denis, can you tell us what is the naloxone demonstration project, and what is it about it that's working?
Thanks, Graham. The naloxone demonstration model was born out of the need that we weren't providing naloxone to service users, to patients, to clients, to users, to prevent overdose. It is only opioid overdose that we have to keep in mind. So around 2005, I went to the Maudsley in London to learn about overdose, and in 2015 2015, I finally got the naloxone project off the ground. So that's your timeline that I had to deal with. In that time, I obviously looked at the Welsh model and the Scottish model, most particularly the Welsh model, because they had initially run out a demonstration project, which is what we did, looking at where high-risk areas were, high-risk patient groups, and in that we targeted very much the our voluntary sector people, most particularly those who had a lot of homeless users who may not even be accessing treatment. We targeted Dublin city centre, north and south, Cork, Waterford and Limerick. And in that time, by the time everything got set up, we ran out training. We have 30 trained trainers for naloxone, and we've cascaded training down to over 1,000 people at the moment with regards who can cascade the training then out to family members and users. And that's the most important group in all of this. Not me, not anyone, but the service user and their family member or loved one. They're the most important people in accessing this product. So in May 21st, last year, the Minister announced the availability of naloxone, and we went live the following day, and the first prescriptions were issued for patients to access it. So since May to December, we have only issued, which is quite interesting, only issued 150 products. Now that might be because it's so limited to locations. However, the plan is that it's going to spread wider as more and more people take up the training. Whilst this was also going on, there was a change in the law. Any of you who enjoy reading the law, I think it's statutory instrument 423 or 324, sorry for my dyslexia, where they talked about availability of naloxone through that pharmacist could administer it, that a worker that had their project registered, that had done accredited training, could access it without a prescription. So again, it's a bit like the whole thing around law. It's going in the right direction, but it needs to be done a little bit more as to make it available that a service user can go into a needle exchange program and say, I need a naloxone, can you please give me one? And somebody can hand it over without a prescription. That's where I'd like to end up. But like everything, it's everything in small steps. And in that time, we've done an external evaluation of the project. And in that time, the other thing that's a very positive aspect of this is that it's been used, that we are aware and recorded on 5 occasions, and in those 5 occasions, there have been 5 saves. So 5 people have been saved. So you might ask, who carried out the injecting? Because I had a huge issue with people giving out to me that clients won't know what to do. You know, they won't understand your training, Dennis. It's too simple, too easy. You know, why isn't it more complicated? Why aren't we doing didactic 6-hour training sessions with clients to use a needle? So essentially the training for clients is, and we've got some star trainers in the room, is about 10 minutes at a push, maybe 15 depending on the client group. Family members take a little bit more because they have a lot of other issues that arise during the training, and we've worked in conjunction very much so with Family Support Network on that, to roll that out amongst family members and for them to tailor the training for those. So we've had 2 peer-to-peer, and people would say, oh, they won't follow protocols. The peer-to-peer protocols and the answers back from talking to peers who administer this is as perfect as you could get from any examination. They followed everything to the letter of what they were told. Project workers reported back they liked the drill, as in because they said when Dennis O'Driscoll and other trainers were giving training, they were very clear on a drill. There was a drill to this is what you needed to do, this was your system that you had to put in place. So from our perspective, I think, I have to say, I think it's successful. For me, 5 people who may have died of an accidental overdose associated with opioids are not dead now.
Can I just add also that you mentioned Wales there. We were able to implement a very similar system in Wales back in 2010, and our records show that it's currently being used in 632 overdose events. So hopefully over time, we've seen only in the last year a 55% increase. So it does take a time, but it does become a faster moving vehicle over time. I think there's trust issues and lots of other issues, but it's really, really valuable.
Thank you very much, the two of you. Dennis, you explained to me earlier that the formulation of naloxone is through injection rather than nasal formulation. I suppose, can you first just tell us exactly what naloxone is, for anyone that doesn't know, and second of all, like, what is the two differences there, and why it is that you chose the injection formulation?
Okay. Thanks. Okay, so what is naloxone? It's essentially an antidote to overdose. But the most important thing to remember is it's not a treatment. It gives people time for the ambulance to arrive. And that's where we differ with some jurisdictions, particularly in the States, and that they see it often as a treatment, whereas we're seeing it as a time to allow the ambulance to come and take over treatment care. So at the beginning of this, there was a lot of issues around, the formulation you're using is an injectable, and needle stick injury, clients using needles, they'll use the needle for groin injecting, they'll empty out the naloxone and fill it up with heroin and carry it around with them and won't be arrested because the guards will see that it's naloxone. None of that has come to pass, believe it or not. Why we went for the injectable formulation was that at the time there was no marketed product in the world that was licensed for nasal delivery. There were organisations using the injectable formulation by putting a little device at the top for insufflation. But those organisations were doing that were predominantly ambulance. And my argument was, if I'm a mother or father at home or a partner with my loved one who's in overdose, I give them this waterboarding of this solution up their nose and they don't come round. I haven't an ambulance behind me to pick up the pieces. So in some ways, they have the luxury of having a mini hospital sitting on wheels beside them. And also, they have more product, because ultimately it would be one product. So the pre-filled syringe is what we went for, because also the beauty of this pre-filled product was that it had lay administration, extra labelling, which comes down to how they license the product in the UK. And by that, it meant that lay people, once they'd done the training, were able to administer it if necessary to people who needed it. So that was another positive step. Ideally, if tomorrow morning that there was a beautifully licensed nasal product on the market, of course that's the product of choice I would go for. But currently the product that is licensed and available and has been used in other jurisdictions, predominantly in Scotland, and I know in parts of Wales and in parts of the UK, in Sweden and in Denmark, that they use the injectable formulation. Once a nasal comes on the market, I'm sure both of us would be delighted to go down the route of looking at a nasal formulation rather than injectable, because then you avoid the whole issue of needle stick injury. The risk is somebody, that's the other thing that you get charged with all the time with the pre-fill. They'll go off and share it and won't use it for anyone else. But amazingly, when people listen to training and say that it's for one individual use, please only use it on one person. When you've used it, hand it over to the ambulance. In all the cases where we know it has been used, it has been handed back to the ambulance. So again, it demonstrates that when clients want to use it, and when service users and staff members want to use it, they do follow what they're asked to do. It's not that they become maverick and go around jabbing it into everyone in the hope that they'll save the whole world and everyone. So there was always that risk with it, but we do in our training cover very strongly about that risk and to be very mindful of it. And also the other thing is that if you talk about harm reduction, then we could argue that with needle exchanges, we continue to say don't share works. We do know that they do share. So then should we close down needle exchanges if we weren't allowed to use a nasal injectable naloxone? Thanks, Graham.
Thank you very much. And can I finally ask you, Dennis, so this has been rolled out, already, through pharmacies and mothers, communities, and some other stakeholders as well. Can you maybe touch on where next? Where do you want this to be rolled out next?
Ideally, everywhere. Ideally, if you look at all the data, the statistics, if you look at a lot of the research, particularly in Scotland, by Barra et al., they would say that it should be 20 multiplied by those who've died of an opioid overdose. So we're at a little bit of, and this isn't a criticism, it's just the way our system works. Our overdose data is always behind. So you must appreciate that I'm working from data from 2013. In order to pick out where to, or actually when I was doing it 2012, to pick out where best to roll this out. So that makes life a little bit difficult. So ideally, in my opinion, anyone who's been started on OST, most predominantly methadone, should receive a naloxone. Anyone attending a needle exchange that would say to you that I would like a naloxone should be provided one. Anyone who has had a previous history of an overdose should have an naloxone. But not only should they get it, because remember, if they have it, it's all well and good, they're carrying it. You need to have the person who's with them trained in how to administer it. So there's a whole piece of work that needs to be done. And I know some organisations like Merchants Key and Anna Liffey Drugs Project particularly have been doing group setting training with clients. Not necessarily that they're getting the product, but just so they're aware that if a friend of them has this box, and sorry I didn't bring a sample along with me, but the box is very, very bright yellow, about this size, this thick. It's a very, very decipherable product. It can be easily seen that if they have this product and they see their friend in overdose, that they will give it. Also, interestingly, from Scotland, there has been some, you could argue, behavioural changes with clients who receive naloxone, that often they, if they're using with friends, tend to be much more cautious about how much they use, because they believe that they have the kind of service there in case one of their friends goes over. But again, very qualitative rather than quantitative, but it's interesting data to look at, that there is that whole piece that we need to look at, that there is a change modification around clients. The other thing, I guess, and I'm sure it will be the same in Wales, is that we need to encourage clients to carry it with them. If they don't have it on them, there's nothing, if you don't have it, can't save you. You need to carry it.
Thank you very much. I'd like to bring the discussion back to drug testing. I think it's really, really topical at the moment. It's very important. With the number of deaths in the past year, even alone, in Ireland, due to misidentification or due to overdose for recreational drug use. Josie, the type of model that WEDNOS provide is a centralised, certified laboratory testing for drugs. You put these up online and you provide a database where people can get information. Now, a lot of people, I suppose, over the past few days, have been giving feedback online and through articles and stuff, who maybe or maybe not consume drugs would comment that the current behaviour for people, for recreational drug users, is that a lot of time it's spontaneous. They might be out in a nightclub or at a festival. It's maybe a trusted friend has offered them something and they've consumed it. Do you think that having the centralised laboratory facilities will, change the kind of trends and behaviours of people taking drugs in terms of that they'll want to research a few days in advance, or they'll want to change the way that they approach it? Do you think that's going to be kind of the shift towards in the future, and do you think there should be maybe a hybrid model of a centralised system and also outreach in nightclubs and festivals as well? How do you envision, I suppose, just behaviours for recreational drug users?
Okay, that was a long question. Essentially, I think our model works in. You're quite right. There is a requirement for pre-thought. We can turn around, and we do turn around samples in 48 hours. So if somebody's buying their drugs in the week for the weekend, which is not uncommon, you can have a sense of what that is and access the service there. And it also, I think, provides a mechanism for people to give conscious thought to their drug taking, rather than it just be spontaneous. That said, I recognise absolutely that in the heat of the night, you will be offered. You will take. You mentioned, a trusted friend. That trusted friend would not want to give you a substance that was going to make you go to hospital, be very sick, or potentially die, or suffer adverse events. I think the communication that we've had back, and we've engaged very strongly with the forums, with people who are using and know far more about these substances because they're experimenters and they're chemists, than we would do. Recognise that actually if we can change the nature of risk, of spontaneity, and also for individuals who are in the market for selling, take a slight more responsibility for the drugs that they are passing on. That is the best we can hope for. It is not to say that we do have the lab. It's a massive piece of kit. There's lots of pieces of kit, and it's very technical. There are opportunities for mobile units, and I know that certainly there's a project. Fiona Mission up in Manchester operates within a nightclub. I think that is possible with caveats. I think that certainly in my experience in the last 2.5 years, we've come across drugs that have 6 different compounds in. With the best will in the world, that takes analysis. And I think that we never say, okay, it's grand. We provide full information on what it is and a backdrop of all of the other pieces of information and evidence that we have from right across the world. So whilst testing in festivals and nightclubs, there are opportunities, but it's slightly more limited, and I think the caveats need to be very clear. In terms of kits that you can purchase, I would stress absolute caution with those kits. We don't endorse them at all. I think that you are asking an awful lot of an individual to become a chemist in that half an hour or so. I think that there is a danger twofold, that people will assume it's safe because the broad brush evidence would indicate it's one thing. That is not enough anymore. Secondly, you're potentially creating a market for less conscientious individuals to create a kit that, quite frankly, doesn't do anything. And you are then perpetuating the problem rather than providing a solution.
Thank you very much for clarifying that, Josie. I'd like to just move the conversation on a small bit and invite the panelists from this morning onto the stage and have a more interactive Q&A with the audience. If Peter, Damon and Mark would mind just coming up on the panel here. No, the current panelists stay sitting. You don't get off that either. So Peter, I'll start with you. We touched on failures this morning, and you quite eloquently, gave us the raw reality of the situation in Ireland. Can you tell me what will work about what is it about decriminalisation that will work?
Decriminalisation will make very little difference unless we reinvest the money in treatment. I think that was the message this morning. Very much so. So decriminalisation on its own, yes, it will have an effect. It will. People who use drugs, one of the if we want people to stop using drugs, it's vitally important that they have some opportunity to reintegrate into mainstream society. If you're on drugs, all your friends are going to be on drugs because your other friends don't want to know you. So they have to be able to reintegrate back into mainstream non-drug using society. If they have a criminal record, that becomes much more difficult. They may be more difficult for them to get employment. They won't get a visa for America or Australia if they want to go off for a few years and get a new start. So we're actually, by criminalising drug users, we're actually marginalising them even more. And one of the primary causes of drug use is marginalisation. So I think there is nothing to be lost by decriminalising drugs. We have to bring the public with us, but there's nothing to be lost by it, and there is a huge amount to be gained.
Okay. Thank you very much. Damon, same question to you. In a human rights perspective, what is it about decriminalisation that will work?
I think what about it will work might be not quite the right way of phrasing it. Sometimes there's things about it that could work. I think it's a bare minimum to stop doing stuff that's both harmful and a perversion of what the criminal law is for. It's not the place for the criminal law with this particular kind of behaviour. So whether it works or not to achieve something else is only part of the argument. It's wrong of itself and needs to go away. So that I'm happy with that. I'll say that it's wrong, and then, as Peter said, we've so much more work to do. In many ways, I think our drug policies need to get out of the way of good social policy.
Aisling, Josie, I'll go to you first. Yeah.
Sorry, just to say that the move to decriminalisation in Wales, we have a devolved health powers, but we have no devolved criminal justice powers. So we are at the mercy of the fantastic UK I'm lost for words. But yes, government and their absolute inability to recognise evidence in any capacity. So we are working in a situation where decriminalisation is not even on the agenda, way far from the agenda. It doesn't preclude local development and implementation, including the police, of really proactive harm reduction interventions for all drug users, whether you are recreational, medicinal, or problematic.
I'd just like to ask you, Aisling, responding to Damon, there's so much more that we need to do. Can you describe maybe what do you, in your opinion, is it that we need to do in order to change? If the goal here is to introduce harm reduction to save lives, what broader reform, so it's from a human rights perspective, needs to happen?
Sure, and I think what I say is not going to be used to anybody in the room, or hasn't in a way been touched upon before. And I agree with Josie. I should say this is not a sequencing thing. When I said, we came to the conclusion that decriminalisation is kind of essential to really get on to good drug policy, we do believe that. But it's not that you can't obviously continue to pursue it. But when you have criminalisation of drug use, you will always have those getting in the way. So you will do your best, and hopefully you will get stakeholders like the police and that who are on your side and stay out of the way. But ultimately, I said, if you want to be realistic about this, if you really want to see drug use when it becomes harmful as a public health issue, and you want to address it in terms of reducing deaths, in terms of improving health outcomes, in terms of emptying prisons for people who shouldn't be in there, and as we said, all the negative consequences that come from even an arrest, it can be bad, not mind a criminal record. So what should we be doing? I have to say, I'm not a medical expert. I'm not a addiction